But it gives me really great pleasure to be the moderator of this panel, which is really going to focus on the worker shortage. You know, one of the main areas, and if we had had time, certainly would have focused more on it, was the whole issue of the shortage of workers. And it's really in an emergency state across the healthcare system. So I think we need to think about home care, nursing homes, hospitals, really across the board. It's a real big issue. So I'm gonna invite each member of the panel to introduce themselves and to perhaps start with some thoughts. Okay. While you're doing that, I'll just queue up those other slides.
Don't bother. Hi, my name is Jean Moore. I'm at the Center for Health Workforce Studies, which is based at the UAlbany School of Public Health. Our mission is to provide timely, accurate information and conduct policy relevant research about the health workforce, to assist stakeholders to better understand health workforce issues, to inform decision making on the health workforce development programs and policies. Now, do you want me to respond to the first question as well?
Maybe have everybody introduce and then, yeah.
Okay. Got it.
Hi, everyone. I'm Dora Fisher. I'm the Director of Post-Acute and Continuing Care for HANYS, the Healthcare Association of New York State. And in my role, my job is to speak to the nursing homes in our membership to help them untangle confusing regulations and to help them to generally listen to their frustrations to inform our advocacy. So I'm here today representing their perspective, the perspective of nonprofit nursing homes that are largely affiliated with hospital systems.
Good morning, everyone. I'm Peter Strauss. I'm a partner at Pierro, Strauss. I've been there almost 4 years. I've had a long career in elder law and advocacy for seniors and persons with disabilities, and particularly younger people with disabilities. And I'm going to talk last about the so-called gray area, which maybe we should be referring to as the invisible market. And I hope I have a little time just to explain the problem and my concerns about how it relates to all of the other issues we're talking about today.
All right, good morning. Thank you very much for having me here at the risk of being the managed care representative up on the podium here. But my career has been in mostly in provider side of home care, and then also now in managed care. I'd love to just talk about the communication needs and the partnership needs regarding all stakeholders, managed care, providers, and then also the workforce, and then ultimately the patients, the recipients of the care. So looking forward to the discussion.
Thank you, Joe. Thank you. And thank you to all of our panelists. I mean, we have really I think a great and diverse perspective here for this. And I think we'll just stay on the group slide if it's okay, rather than on the data. That way we can address the audience, and those that are remote can I think can see us better. So our format is going to be, I'm going to pose a question, and each person on the panel is going to respond to the question and provide a perspective on that. So the first question to each person, Jean, I'll begin with you. What is your perspective on the health workforce shortage from your position in the healthcare system?
So let me just say that for a long time,
I don't think that's it. I don't think it's.
for the longest time, we have.
Sorry, Jean. Yeah, it's just now not working.
It was hard to acknowledge workforce shortages in New York because New York has an abundant supply of many health professions. So when you compare New York to other states, more physicians, more nurses, more this, more that. So, but we're the first to admit that they're not particularly well distributed. They're not where we need them. And so, for example, we have seen chronic shortages of primary care, oral health, behavioral health providers. And in fact, there are many areas, inner city, urban, rural areas, they're designated as HPSAs. And there are health professional shortage areas. It's a federal designation. And that designation can create access to provider incentive programs that actually have worked pretty well in getting healthcare practitioners into those communities. At the same time, we've seen that home care, long-term care providers have had long-standing workforce recruitment and retention issues. So our center, on an annual basis, surveys hospitals, ambulatory care centers, home care, long-term care providers to just say, what are the most pressing recruitment and retention issues, challenges that you're facing? And I'll share with you the most recent results from that, but I just want to say that the COVID pandemic really kind of turned things on its head. I think that there were problems before, but the problems now have become much, much worse. And I think initially the state responses to, the fact that, hey, we needed more workers than we had, demand for services was going up, up, up. So there were executive orders that were introduced that increased regulatory flexibility and scope of practice, something that certainly makes a lot of sense. Facilitating the licensing of healthcare professionals interested in working in our state. So those were the sorts of things that were in play, at least initially, and had some effect. But again, I think that the shortages that providers face have been continually worsening. So for nursing homes and adult care facilities, they reported the occupations most difficult to recruit were RNs, LPNs, CNAs, and they cited general shortages as the reason. And essentially what they said was there just aren't enough workers. They're simply not out there. Most difficult occupations to retain, newly licensed RNs and LPNs. The newly licensed RN issue is an interesting one because I think that pre-pandemic, newly graduated RNs might have trouble finding a job in their first choice, which is probably acute care, and went to long-term care. They got the experience in long-term care and then left. So that was part of the reason why they just didn't stick around. I will tell you that things have changed now with the health professions education pipeline. So we learned that many nursing education programs had a great deal of difficulty getting their graduate or getting their students the clinical experience they need. And I'm sure you've all heard they moved to simulation as a way to get the job done. They provided experiences for students that were sort of away from direct patient care because providers were saying, look, we got a crisis here. We can't add a bunch of students. It wouldn't work out. So students use, nursing programs use simulation to help students through. So then what happened? Then these new graduates went into clinical areas and just weren't prepared because they didn't have the experience under their belt that they really needed to be able to function effectively. So again, I think that we're seeing turnover in newly licensed RNs, not just in home care or in nursing homes for the reasons previously cited, but because they are less prepared for practice because of the things that needed to be done to help the students graduate. Home care agencies, the most difficult occupations to recruit, home health aides, home care aides. Reasons, general shortages, again, not enough workers, fear of COVID. Another kind of new and important reason for wanting to leave. Most difficult occupations to retain, personal care aides, home health aides, homemakers. Reasons for leaving, better paying opportunities, family commitments, transportation issues. So again, some of the reasons for why people don't want to stick around or why they don't want to take jobs have changed as a result of COVID. And I will also say that we're seeing general workforce shortages. This isn't just a health sector issue. It's Target, it's Amazon, it's Panera's. And they are waiting to recruit some of the people who are working in healthcare who are saying, I'm burned out, I'm scared, I really don't want to bring COVID home to my family. And for whatever reason, maybe leaving healthcare to move into other areas, who greet them with open arms and sign-on bonuses and flexible hours and the things that perhaps attract them. So I think my perspective is that we do have shortages, and shortages that are likely to worsen. Recognizing that, again, labor shortages are becoming a sad fact of life just about everywhere.
Thank you so much, Jean. And, it's really interesting to hear Jean's, 1,000-foot view. All of the research reflects what I hear from our members. In communicating with our members, which I do every day, it's clear that they are passionate about providing quality care, high quality care to nursing home residents. But we all know that in order to do that, maintaining a robust and stable workforce is critical. That is the cornerstone of providing that care. And they all want to do that. That's why they got into this field. And unfortunately, as Jean mentioned, this crisis did exist before the pandemic. We had a study from 2018 showing that nursing homes had an average turnover rate from their frontline staff of 95%, meaning that they are replacing their entire patient-facing staff every single year.
Wow.
And that kind of turnover is really damaging to the quality of care that you can provide. So, the problem has been greatly exacerbated by the pandemic, as Jean mentioned. However, the root causes date way back. We need to talk about the chronic problem of Medicaid underpayment to nursing homes. We cannot address this problem if Medicaid is going to continue to pay nursing homes so far below the cost of care. And not to mention that there is also an outdated and overly complex regulatory framework and reporting requirements that during a staffing shortage, we have care providers focusing on paperwork and on, making sure this dot is this T is crossed and this I is dotted, instead of providing care to patients, which is what they all really want to do desperately. And I'll leave it there. I have some rosier things to say, but I'll save them for the other questions.
I'm going to really hold most of my comments on the questions that Al is going to be asking initially to the end. But I do want to say that the shortage of available aids in nursing homes and home care is exacerbating the problem of the gray market, because if people can't find aids to keep them at home through the organizations and Medicaid, then they're going to do other things. And I think that's going to force them to go, quote, independent and off the books, et cetera. So that issue, which I'll address a bit, give some thoughts toward. I think if I can get us a clean 5 minutes at the end, I'm going to try to do that, but I'll pass.
Okay.
All right, and it's a great question, and I was trying to put some numbers to it and thinking about this, but it's the worst it's ever been. This issue, as was just mentioned, has boiled up to other industries, right? Even as a health care, as a managed care provider, finding individuals to man phones and it's very, very difficult, right? Everybody's saying, I'm going to work from home. If you can't figure out a way for me to work from home, I'm going to go find something else to do. And so as that's boiling into all these other industries, home care is that much harder. I think what I would focus on is that the workforce shortage, and there is Nascentia serves 48 counties, all of upstate New York, everything above the mid-Hudson. So I'm going to kind of leave my context there. What has happened over the last couple of years, and we've seen a tremendous shift from home care, traditional home care aides to CDPAP and PA. And it's just, there's a huge movement there. 20 years ago, you saw the certified home care agencies take a step back, and the LICSAs, the licensed home care agencies, and the PCAs step forward. Now it's the PCAs stepping back and CDPAP being the vast majority of how this care is provided. In the upstate market, 48 counties, right? So everything above the mid-Hudson, 75% of what Greg and Alan were talking about earlier, where the state is spending dollars on home care, 75% of that today is being spent on CDPAP. That's an MLTC world. In the regular managed care world, MMC world, it's 85%, right? Every month we look at this and we see, I've seen months where every month it's a percentage change difference. PCA down, CDPAP up. I don't know what the right number is. CDPAP is a phenomenal program, right? It's great benefit. But is our programming, our state programming, the education efforts that we're doing, the dollars that we're sending, are we focusing those dollars on where the industry has moved, or are we still focusing those dollars in other areas and target? And I think that's a huge conversation that needs to happen on the policy front, is how do we engage CDPAP? How do we make it part of all of those conversations and ensure that the members get served? Because right now, many of the fundings and the mechanisms are not going to CDPAP, they're going to other streams of providing care.
Joe, that's such a critical issue. I think, Lou, we could spend an entire session, maybe an entire conference on that, because what's happened over the last, 20 years or so, 20, 25 years in the development of this, is that you really sort of have a bifurcated system. You have two parallel tracks going on, and is policy and program, is it all talking to each other? And does it make sense in the system that we have? In terms of the next question, and maybe Joe, we'll start at your end and then we'll work back this way, is the newly adopted state budget committed new resources and programs to address workforce needs. This is a twofold question. One, what do you think the impacts will be of these new resources and programs? So, for example, the mandatory wage increase, the bonuses, the new Office of Workforce Innovation, things along those lines, and what further needs to happen to address those needs, and in particular, what needs to happen programmatically and fiscally in the immediate?
So I'll just speak to a couple of points, because there's a lot of changes that are coming. But I'm going to tie it back to some earlier comments in the program, right? There was the fair pay for home care that was making its way through, where the idea was that anyone working in home care would make 150% of minimum wage, right? That's what was making its way through the budget. And I think many of us, including ourselves, and Nascentia is a provider-sponsored health plan. So we have health plans, but we also have providers. We have certified agencies, LICSAs, et cetera, serving the upstate market. But we looked at that and said, absolutely, that's got to have to be part of solving this need, is that more dollars go to the workers, right? And it's not just about pay. A lot of times it's about communication and other things, but it's about dollars. So the fair pay for home care, was ultimately changed, and it became a $3 more per hour directed towards that workforce over the next 2 years. That's starting. $2 is intended to start on October 1st. Now, the devil's in the details here, because it's not really $2. It's $2 plus benefits, plus administrative cost of the organizations that have to manage all of that. And so at the state level, they have to figure that out, right? And they don't have a lot of time. You basically have 2-3 months to figure out how to get that out there. And the other large shift that's happened just in the last year is on the managed care side, and it gets way in the weeds, but on the managed care side, the state has moved away from, okay, let's start paying managed care plans based on what hours their members have, to let's do things regionally. And so when that happens, and it started with minimum wage, it moves everybody to the middle, and it hurts the plans that are paying, that have the most acute, highest need members. So if you think about the last even 5 years, which managed long-term care plans have left? You know, the ICSs, the Centerlights, the organizations that were focused on taking care of the most complex members. And so this is a huge challenge to actually make this work fiscally. And I would just say that one initiative is going to be, you know, there's a lot of dollars tied to that, but that's going to be a very big challenge in the next 3 months to figure it all out.
Sure. I'll keep my comments on this question brief, but you know, we at HANYS were very pleased to see the state acknowledging this issue, the workforce crisis, and working to address this problem with some investments. However, we are very concerned that these investments do not go far enough to address both the house on fire emergency that we are in right now, and the long-term structural problems that got us here in the first place. So we are really gravely concerned that the recent investments made by the state, while are promising and interesting, we're really concerned that some of the root problems, particularly Medicaid underfunding, have not been addressed. Nursing homes have not received a real meaningful increase in about 15 years. And considering, how much it costs to fill up your car to go to your job at a nursing home, we need to see wages increase, and that cannot happen without significant investment in Medicaid. But again, I do want to say that we really appreciate the investments made by the state. We're really excited about the Workforce Innovation Center because we think there is a lot of great research to be done and new models to explore to help us with this issue. And we're going to continue beating this drum until this is addressed appropriately.
So in terms of investments, I think it's really important to ask ourselves, so what are the problems? Because if we don't understand the factors that are driving this shortage, it's going to be pretty hard to develop effective strategies. So some areas include the health professions pipeline. Are we producing enough of the workers that we need? Is there interest in the profession? Do we know about the extent to which people want to become nurses, doctors, NPs, et cetera? Are there capacity limits on programs? So for many years, we've actually surveyed nursing deans and directors about turning away qualified applicants, and if so, why? And one of the things we hear from them is that they do have capacity limits. They, think about the fact that community college tuition doesn't come close to what it costs to provide a clinical education for a nurse. So that falls short. I think that right now we're actually working on a survey of nursing deans as we speak. There's a serious faculty shortage. Many faculty are retiring. Others are going off to become travelers or get better paying jobs. That will clearly impact the capacity of nursing education programs and could actually result in a decline in the number of new nurses produced. Another issue just relates to clinical training sites and the extent to which there's a whole lot of competition from different professional education programs for a limited number of training slots. So again, I think that we need to look carefully at the pipeline and understanding who we're producing and what the issues are and whether they can be resolved. Another, as I mentioned earlier, job readiness of new grads. Are we taking new grads, putting them into positions that they're not particularly well equipped for, and are we mentoring them? Are we giving them opportunities to learn from more experienced people who probably left for other jobs as well? I think that we have a lot of sort of interlocking issues that we need to look at. Wages and benefits, this has come up a whole lot, but I will tell you, I don't think money alone or a salary boost is going to solve this problem single-handedly. I think it's important to understand, what do workers want? What are their big issues? I was talking to someone yesterday actually about the chief learning officer at a large health system downstate, who talked about the fact that, so she's interviewing candidates for jobs, and it's like they're interviewing her. What can you do for me? What can I expect? And the fact that it's hard to find mission-driven people. I think that generational differences are really critical to understand. I think that, baby boomers, we all work to live while others, live to or whatever. You get my point. But the point is that they don't plan to stick around that long. And so when we recruit people and plug them in, we need to understand that we need a system that allows us to fill behind the people leaving because they're off to do something else. And so I think that, recognizing what's on their minds and what they want is really critical. Opportunities for advancement. Do we have career ladders? Do we have home health aide career ladders? Can we take a home health aide and say, in 2 years, you'll be an LPN? Do we have systems that work, that make people want to stick around? Again, I think we've all kind of dabbled at that, but it feels like we need something more systematic, and we need something that we can show actually works. I also think leadership training. Again, we take good staff and say, okay, now you're a supervisor. Did they get trained? Did we provide them with the tools they need to be effective at that? Working conditions. I think flexibility in hours. I think back in the last nursing shortage, everybody loved the 12 hours, 3 days, and that worked great. What do new grads want? Does that work for them, or do they want something else? I also think something we don't look at enough is the culture of our organizations. Do we treat people with respect and dignity, not just staff, but patients? Is that something that is important and that we make sure people understand? Finally, I think building workforce resilience. Again, I think that for many people who are leaving healthcare, they're burned out. What are we doing about that? What do we have in place that say, you're important, we really want to help you through this, we really want you to stick around? And I just a couple of other things. I think scope of practice. I mentioned back early on in the pandemic, we saw some executive orders. We saw some executive orders that actually facilitated better scope of practice. And by better scope of practice, I'm saying we're letting people do what they're trained and capable of doing in an emergency. And then we say, okay, now we're done. Now you can't do that anymore. What? I feel like we can't afford that. I feel like we can't afford to take people who are trained and capable and put limits on what they can do. And finally, my pitch, which I always do, is we need better data. When people say to me, how many nurses are there? How many nurses in home care? How many nurses in hospitals? No, we don't have good data. We can provide some rough estimates. Now, the good news is there's a bill that passed in December. We call it the Health Professions Data Bill, mandatory re-registration surveys for all health professionals. So we will soon be able to answer those questions in great detail. So better data is critical to our understanding of who we've got, where they are, what they're going to do next, what they look like.
Thank you, Jean. Thank you, Jean. I think you gave us a head start on what our next question is, which is what can be done to encourage new entrants in healthcare, home care, long-term care field from high school and up. And I think you were a great segue into that very area. Do you want to touch on that? And then
I'll just say a few things. Number one, I think, and somebody mentioned this earlier, we need to start early. We need to be in grade schools, middle schools, getting people to think about health careers. I think that if you were to ask a guidance counselor about health professions, they'd say, well, yeah, there's doctors and nurses, right? And people don't see the whole spectrum of opportunity. I think we need to provide STEM support to focus on academic achievement. I think that health professionals need to get into schools, meet and greet, and share what they do. Shadowing, mentoring, MASH camps. Last nursing shortage, we did wonders recruiting second career candidates who said, I want to do something meaningful. I really want to get into nursing. And it worked. And again, creating viable career ladders. I think that you can't invite somebody into a job without giving them some ideas to think about opportunities for advancement and promotion and build something that actually works.
Thank you. I agree with Jean on so many wonderful points. You know, we need to look at this problem structurally to make sure that we have the infrastructure in place to build the healthcare workforce that we need for tomorrow, for today, but for tomorrow. So, you know, as we've said already, we know that an entry-level job in a nursing home will pay about the same wage as an entry-level job at Walmart or Dunkin' Donuts. And a lot of my member nursing homes are losing employees to those jobs. But the key difference between those jobs and a job in a nursing home is that you are starting a career. You are beginning something that is meaningful to you, that if, you know, so for some people it's just a job, right? But there are always going to be some people who fall in love with it, you know, people who realize that care work is their profession. And we need to make sure that we have the infrastructure in place to support that ladder. So someone starting out as a CNA can one day become a nurse manager, maybe even a nursing home administrator. And that we need to make sure we have that infrastructure. And, you know, as Jean said, we do need to start earlier and make sure that we have that infrastructure. I know that SUNY has invested over $3 million in creating new nursing student slots. I think something like 1,500 new nursing students a year across the whole system. We also know I know that McDonald mentioned this earlier this morning about how there are new charter schools that are working on healthcare professions at a pretty young age. And I think these are the kinds of things we need to support. And one last point is that we also need to talk about culturally competent workplaces and diversity and equity and inclusion in the workplace in order to support new entrants to this healthcare system who are people of color and immigrants and other populations, to make sure that it is a workplace that they feel safe and comfortable returning to.
Thinking about this topic, I was able to speak to our own organization on the provider side, but then also survey some organizations. And quite honestly, I didn't just talk to LICSAs, I talked to FIs, who are fiscal intermediaries who in New York State are the administrative portion of running the consumer-directed program in the back end. And it's, you know, similar answers. As was mentioned earlier, it's not just about pay. Pay is important, but it's not just about pay. It's about, you know, good communication. Organizations that are out there that have been successful in developing this. And again, I'm going to say it's really the FIs. And I know the FIs, that's consumer directed, right? It's the consumer hiring, but in the reality of 75 to 80% of this, the FIs are very involved in this process, right? So a lot of organizations now are using technology, right? Match.com type of service, not just is the individual a smoker or is the individual have pets in the home, but trying to go deeper into the personality traits of the individual to be served and, you know, the potential workforce, which I think is, you know, really interesting. And, you know, maybe there's more technology there, because if we have these huge turnover numbers, and we do, nursing home was mentioned 95% turnover. Home care, it's very high. You know, I've seen it's at least 25%, but I think I've seen higher numbers than that. Can we match individuals early on, right when we're starting, you know, connecting the dots there to help it to be successful, and that would, improve retention, but also right from the beginning with recruitment.
So I'm going to break my silence. The silence was in part to demonstrate that the entire day today, with all the wonderful information and creative ideas and the talent here to address the very specific topic of this panel, the day has been silent about the silent workers, the unknown gray area. We don't even know how many people are employed privately by someone like Dorothy, who's 90, who has moderately advanced dementia, whose daughter lives in Chicago, who needed assistance at home because she was, leaving the gas on the stove. So she talks to her housekeeper. Do you know anyone who could be, the daughter talks to the housekeeper, do you know anyone who could be an aide for my mother? And she says, yes, I have a large family from wherever it is, the Philippines, Russia, you name the country. Many have green cards, many do not. She could do this job, and so fine, the daughter hires her. Forget whether there's any legal agreement, which in some cases there may be a letter, and the aide is paid in cash or by check made out to cash. There's no unemployment insurance, there's no disability insurance, there's no workers' compensation. And another point that most people don't put on this list is nobody's paying the Social Security tax. So not only is the aide violating the law, the employer is violating the law. And then when the aide gets to be age 65 and files a claim for Social Security benefits and is told there's no account for this person, we've never heard of him or her, what's going to happen to the employer? This is all going to come back to bite them in the rear at some point. So this is the problem, and nothing that was said today affects this. Maybe there is some attention, maybe the Department of Labor or the New York State Department of Taxation will begin to look into it. But do we want that? Is this force filling a void that is needed? Are the clients, as consumers, being helped or being they hurt? These people don't have training. Their experience is one, they maybe had two other jobs. They worked one for 6 years and one for 3 years, and now they're working for Dorothy. So what would these people do without it? These people largely can't get Medicaid, and that's going to get worse when the 2.5-year look back period kicks in. So we're going to have more people who won't be able to get in CDPAP, which is a great program, and other programs. So what do we do about it? Do we want to start enforcing these laws so this stops? Do we want to put people in prison because they're violating the tax laws? Of course not. So I don't know the answers, and I'm not trying to be judgmental about this. Do we even want to look at it? Because that could open up a whole series of issues that may not be good for our community. So what I'm saying is, let's know the problem is there, and let's figure out what we do to solve it without hurting people. Both the people who can't afford paying privately at $35 to $40 an hour in New York City through an agency, or the cost of memory care units for a private room in Manhattan and these wonderful new gorgeous hotel-like assisted living facilities. A client just told me that his mother's cost in a memory unit is $19,000 a month. Well, what do nursing homes cost? So I don't know the answer to this. We don't know the numbers. New York Times reported recently that 2/3 of funding on home care in America is from government benefits. So does that mean that there's 1/3 of that total cost that's being spent in the gray market in America? We don't know even how many people are involved in this. So I'm going to leave it at that, but I want to say just one other bit of information. I was shocked. There was a New York Times article recently on Medicare Advantage plans. Did you know that 13% of claims of consumers who are enrolled in Medicare Advantage plans are rejected initially? These are for CAT scans and treatment decisions. I mean, I was shocked. You can look that article up in the Times, and this is from a Health and Human Services Inspector General's report issued in April. Thank you. Just think about this, please.
Thank you, Peter. We want to, do you have that, Dora? Clearly, that whole area that you raise is, you know, I was just saying a few moments ago about like the parallel structure that we have, where we have the whole consumer-directed CDPAP type system, we have the whole regulated system, and now you really brought up like the whole other rail of this. But I think that also speaks, and I know we don't have the answers today, but it's so critical you put this out there, because I think that also speaks to the importance of a coordinated policy. Because the more you push over here, you push over there, you're forcing the air over there in the balloon. You know, and having no idea really what the implications are of that. And that hits both ways. In one way, it's that, okay, you know, where individuals are trying to bear the cost, they're trying to survive, they're trying to make it happen. And if they can't find what they need in coverage or in it supports through the formal system, they have to turn somewhere. And so, you know, it's really in many ways, it's triggered by I think the lack of an organized, cohesive approach to what these needs are, you know, within our system. I know we were going to really try to focus on one more question. If we have a few more minutes, just 5 minutes, and we want to talk about retention and what are some of the things that the panel thinks are critical for retention in the workforce. And Dora, do you want to lead us off?
Thank you. You know, this is a really important topic. Retention is elusive, and it's very different from the pipeline issues that we have explored with recruitment and getting new entrants into the system. With retention, you know, there's many reasons why turnover is so high, right? So as Jean mentioned, yes, the younger generation of workers may not approach their jobs in the same sort of long-term way. That's one reason. Another is burnout, as we've talked about. These are incredibly grueling jobs. They always have been, even before the pandemic, which made that worse. And finally, you know, issues of retention are often intrinsically linked to issues of poverty. You know, we have people from underserved communities who experience the structural inequities that lead them to have a lot of issues with retaining employment. You know, childcare, elder care, transportation. You know, one member said to me, he said, I know that it's never clearer to me than that our system is failing than when I lose an employee because they have to stay home to take care of an older adult in their life, right? I mean, the irony of that, the sadness of that. So, you know, failing, you know, these are obviously huge issues that can't be solved with one thing. But a lot of our members have employed some creative solutions to help with retention. And as we mentioned that they are issues that are often linked to poverty, a lot of the solutions have to be linked to that as well. So, for example, one of our members realized that they were losing staff. You know, they realized why is because they were one of the only nursing homes in the region that wasn't on a bus line. So they used DISRIP funds to create a partnership with Uber to create accounts for, you know, it wasn't for every employee to get there by themselves to and from work every day, but it was enough money to help if somebody's car broke down, or maybe they could share a ride with a coworker. So that was one promising solution. And other members of ours are looking into potentially providing childcare on site or creating new ways to have schedules being more flexible, because you can't assign someone a 7 a.m. to 3 p.m. shift if they don't have childcare until 9 a.m., right? So we need to be mindful about these issues. Other members of ours are looking into, for example, there are these third-party systems that can pay employees daily, such as a Pay Today app. You know, the 2-week paycheck cycle benefits the employer, but it doesn't benefit the employee, particularly employees who maybe they don't have a savings account to float if they have to do a car repair in order to get themselves to work. These are systems that pay an employee every day. They clock in on an app, they clock out, and then they get paid. And I'm not here to say that that's the solution. I can't even tell you if what the results were of the Uber partnership. What I'm saying is that now it is the time to throw spaghetti at the wall and see what fixes, because we are in an emergency. And you know, it's really exciting to see all of these creative solutions being considered.
And the only thing I would add is I'm aware of a large federally qualified health center that just surveyed its members or its staff to ask about what their issues were, to try to build solutions based on what they hear from staff. So again, I think you're right. I think that we all need to think out of the box and be responsive to the people who work for us.
Joe?
You know, in thinking about this, it comes back to good communication, flexible work, the ability to have somebody maybe step out of a role and into another role for a period of time. So, you know, it depends on, you know, how large your system is or your providers are. But if somebody can move from one job to the next, career ladders, we've seen that, but also just recognition, you know, recognizing birthdays and sending them a birthday card and just saying, you know, happy birthday, you know, thank you for being part of the team. And, you know, attempting to listen to employees and hearing their concerns, as was mentioned, but I'll mention it again, just listening and trying to communicate and hear, not solve their problems, but hear not solve the problems we think they have, but hear their actual problems and then try to solve those.
Thanks, Joe. Peter, do you want to comment on that? No?
I would also like to say that maybe we need some employer training. I don't mean the businesses, I mean the parents or the children of the worker in that home. I just attended a funeral in the living room of a friend, and she had an aide through Medicaid. I think it was CDPAP. She attended the funeral and she asked if she could speak. And when the family got through saying their comments as eulogies, this aide got up and talked for 5 minutes about this woman who had died. It was the most remarkable thing. Something happened there that is the example for what you guys are talking about. Respect, honor. This person was important to that family, and she felt the person who died was important to her. And that, I think, should be our goal.
Peter, I think that just struck a chord with everyone here, you know, in terms of focusing on really what is so important in all of this. And you know, I think, you know, it's been said really throughout, you know, what are the values that really come through in the decisions we make in this field, whether they're about funding, whether about the workforce, the patients, and so on. CMS has an initiative that was really a quality initiative called "What's Important to You," and it's sort of a rhetorical question, but programmatically that gets posed in the hospital setting about what's important to that patient in their stay. You know, is it about how many times they were woken up during the night to have their vitals checked, or was it about other aspects that relate to the care? And I just would submit that that's equally important in terms of the workforce and the individuals who work and deliver the services. What is important to you, and how is our response to that reflective of our values as a society for people who do that and for those that receive their services? I just want to really thank the panel again for tremendous comments, and for the audience and all of you. And thank you so much. Thank you, Al and panel. Just a couple of comments. When I started practicing, Medicare provided home health care. You were eligible for 35 hours a week, and it wasn't simply skilled nursing post-hospitalization, it was extended care at 35 hours a week. That went away in 1997 with the Balanced Budget Act, when they took home care and a lot of the other services. You had a team of people. It was a wonderful service prior to 1997. And you know, maybe we get back to some Medicare in this area. We're going to hear about that on the next panel. But New York took the position, let's make it Medicaid. They made Medicaid a verb. And every program that was available, New York brought in. So all of these programs, we have 5 different home care programs, and Medicaiding it became the norm. Is Medicaid where we want this service? Do we want people to have to be impoverished in order to qualify for essential healthcare services? That's how our system has been built. We talk about that a lot here. We talk about other programs, innovative programs. Greg and I worked on one called the Compact for Long-Term Care, which would have helped some in this. But think about this statistic. I've been doing a lot of demographic research. And in 2100, for every 100 people, 77 will either be under 15 or over 65. That leaves 23 people in working age to be able to provide all the things that we're talking about, and in addition, all the other jobs that need to be filled in the country. So it's a startling statistic when you think about it, and it's a little ways away. But when we have the 50th Elder Law Forum, Peter will be there. And actually at the 50th forum, I will be Peter's age, which, can I tell him, Peter? Peter's 86. Oh my gosh, Peter. and working every day. And he was practicing law when Medicare and Medicaid were passed in 1965. Think about that. He was in the building. He was practicing law at that point in time. But will my companion in 50 years, in the 50th annual, be Rosie the robot? Are we moving in the direction of having to rely on that level of technology? IBM's already doing it with Watson. They have in-home robots that they're experimenting with that can actually provide care. And in all of the professions that are lacking people, technology, innovation, artificial intelligence are going to have to be part of the solution. So you're going to want to come back after lunch for the innovation panel, when we're going to start talking about some of the technology solutions that are available today and where that technology may be going in the future. I want to thank this panel. Another round of applause for our panel.